Okay, and good evening. Again, welcome to the third installment of this, our Basics of Mechanical Ventilation online course. My name is Neil Ferguson from the University of Toronto and Toronto General Hospital. I'm here again tonight with Thomas Perrano, clinical specialist and respiratory therapist from St. Michael's Hospital here at the University of Toronto. We've given you and Gallagher the night off tonight, so it's just Tom and me tonight. And we're going to build on themes that we talked about last night, and maybe move slightly from basics of mechanical ventilation to maybe a slightly basic to intermediate level tonight. I'm up first, and we're going to talk about for 20 or 30 minutes about basics of ventilation, focusing on spontaneous breathing. I forgot to tell you last night that I have a couple of disclosures, none of which are particularly relevant to this talk. I'll also disclose that if you're looking for this Neil Ferguson, you're in the wrong place. There's a much more famous Neil Ferguson who spells his name funny like I do. Although when I was searching for these book covers, I did learn an important lesson from him. This is the Empire, Rise and Demise of the British World Order. This is the book cover on Amazon.com. On Amazon.co.uk, however, it's Empire, How Britain Made the Modern World. Clearly, the lesson here is pitching your message to your audience. So I'm going to try and do that to the right level tonight. Here's what I want to talk about. How much spontaneous breathing is going on. Talk about some pros and cons of spontaneous breathing, particularly in patients with acute respiratory distress syndrome or COVID-19. And then we'll move a little bit and get to the point where when you talk about spontaneous breathing, now you have to start thinking about synchrony, and is the ventilator working with the patient? So we'll talk about steps to recognize that, and then some methods to reduce asynchrony, make the patient more synchronous with a ventilator, and then sum up. So here's a graph from a worldwide survey of mechanical ventilation practices, now coming up for 10 years old. It shows that on any given day, what was the most common mode used. And you can see here that on the first few days of mechanical ventilation, this is volume cycled assist control was the most common. But this purple line here is pressure support ventilation, which we know for sure is definitely only spontaneous breathing. And its use increases each day. And by the second week, it's the most commonly employed mode of ventilation. And that's a big change from 10 or 15 years earlier, which I have just up here, where this all across every day of up to day 28 was all volume cycled assist control ventilation all the time. Every other mode was just jumbled down in here. So we're seeing more and more spontaneous breathing being used. So pressure support, just to remind you, there's a slide from last night. It's patient initiated. There's no set rate. The patient asks for breaths. It's limited by pressure, and it knows how to cycle in between giving flow on inspiration and then letting the patient passively expire when the inspiratory flow drops to 25%. That's the usual default set rate of peak inspiratory flow. Now, what's good or bad about breathing spontaneously? So first, a few concerns why you might not want to have your patient breathing spontaneously, particularly when they're extremely sick. One is that there may be important vascular effects. When the patient makes significant negative efforts here, that's also felt by the pulmonary capillaries, and you can draw fluid into the interstitium, which then may flood alveoli. There's also an increasing recognition that spontaneous breathing can also lead to lung injury. So we've known about ventilator-induced lung injury for 25 years, but now we're recognizing increasingly that the patient may also be contributing to this. And this is a nice review article or a thought piece that Laurent Bouchard, Slutsky, and Antonio Pacenti, three of the sort of international giants of mechanical ventilation, put together a couple of years ago. So you start off here with a patient who has an initial lung injury from whatever cause, pneumonia, sepsis. They have some capillary leak, they have some lung edema, they have some impaired gas exchange and mechanics, and they have a higher than normal drive, which then creates more pressures across the lung, maybe can cause regional shifts in ventilation, which we call Pendelluft, which cause further lung injury, further capillary leak, and this becomes a bit of a vicious circle. It's not a new concept. In fact, this is a paper from 1988 showing that ventilation, not ventilator, but ventilation-induced lung injury does exist. These were an animal experiment where they injected salicylate directly into the brains of sheep, which made them hyperventilate like crazy, like a lot. Respiratory rates from 25 up to 70 breaths per minute, and tidal volumes up to 10 to 15 mils per kilogram. But no mechanical ventilators were involved in this experiment whatsoever. And when they examined the lungs of pathology, they saw severe lesions in the majority of patients, sheep, in this hyperventilation group. So negative pressure can definitely injure lungs as much as positive pressure. We're also becoming increasingly aware that when the patients are breathing, this can cause shifts in how the breath is delivered within the lung. And this is using a technology called electrical impedance tomography. It's not so important to know the details of that for these purposes, but it essentially allows us to track how air is moving in and out of the lung across different regions. And in this nice pig experiment here, Takeshi Yoshida showed that when these animals were breathing spontaneously, there were large parts of the breath that initially went to the bottom of the lung, and then in the same breath, they all went to the top of the lung. So although the overall size of the breath was relatively normal, it was functioning like a double breath because all of it was going to one part and then later shifting to another part. And that's a phenomenon called Pendulum Twitches, the German literally for swinging air. We also have some further information from laboratory studies. This is a rabbit experiment with mild in some or severe in others. So the mild injury was just saline lavage. The severe injury was saline lavage plus intentional ventilator-induced lung injury. And when the rabbits with mild injury were paralyzed and had no spontaneous breathing, you can see there's a little bit more lung injury at the end of experiment. Here, this mild injury with spontaneous breathing led to the best looking lungs. But in patients with rabbits with severe lung injury, when there was no spontaneous breathing, when they were paralyzed, less inflammation, severe injury with the addition of spontaneous breathing, much worse, and much worse than the mild injury with no spontaneous breathing. So there seems to be an effect modifier of the severity of lung injury about how much spontaneous breathing we should be letting happen, at least in the early phases of the disease. Now, that sounds like all bad news, and you would be forgiven for thinking, oh, we should just paralyze everybody who's on the ventilator. But that's obviously not practical, or won't lead to people coming off the ventilator very quickly. And we also have some information on the other side. So this is one of the large studies of higher versus lower PEEP that we discussed briefly yesterday. This is just to show you that in the fine print of the table where they tell you all about all the different ventilator settings every day, down here in the fine print it says, oh, as soon as the patients got into the weaning phase, where their PEEP was relatively low, less than or equal to 10, and their oxygen levels were less than or equal to 40%, they could be on pressure support mode, and we didn't care what their tidal volumes were. So that tells us empirically that at least when patients are getting better and their lungs are not as injured, it seems that we don't have to fuss as much about worrying.
Hi there, sorry for the technical difficulties. While we wait for Neil to try to get back on, I'm going to present my part of the evening, which is troubleshooting. And I think if Neil comes back on, we'll get him back to finish the rest of his slides. What I'm going to talk about is essentially how to recognize different problems based on ventilator graphics rather than just the numbers, because sometimes looking at the numbers may not tell you as much as looking at the graphics. So I think it was mentioned yesterday that, you know, waveforms are kind of like the, it's like the ECG of the lungs, essentially. It really tells you a lot about what's going on. So just to review to some disclosures I mentioned last night, I have received speaking or consulting fees from Drager, Fisher & Paykel, and Phillips, but absolutely nothing related to this presentation. So I'm going to talk about how to recognize secretions, bronchospasm, pneumothorax, atelectasis, leak, malfunction, and alarm settings. I will discuss at the end in terms of what are probably the most important alarms to set on the ventilator. Now, what I've done for each of my slides, and I'm just going to change the color of my pen ink here, I have normal pressure control waveforms on the left and volume assist control waveforms on the right. So the top one is flow, and the bottom one is pressure, flow, and pressure. Now, with secretions, essentially to understand what changes on your waveforms, you need to understand, is this a compliance problem that we're going to be facing, or is this a resistance problem we're going to be facing? And of course, if you can imagine secretions in an airway, we're probably going to have resistance problems. And resistance, basically what we're looking at is there's a change in pressure and it's relative to the flow. So resistance is inverse to flow, and the change in pressure, this is the relationship that we're going to be using, which is similar to, let me just draw this one over here, compliance as the change in volume over the change in pressure. So these are the two different scenarios that will help you to understand what waveforms should change and how. But let's start with secretions. So with secretions, in pressure assist control, your pressure is constant. So this is not going to change. So if your resistance increases, it's not going to be your pressure, for example, it's going to be your flow. So how the flow changes is generally what you'll see a very noisy flow pattern. And sometimes you'll see it in the inspiration, but you may not always see it, but you will usually see it present in the expiratory flow. And it could be very rapid, it could be less rapid, but you will see alterations in the flow. And of course, alterations in the expiratory flow can always potentially be patient effort, but usually when it's not that rapid. So troubleshooting this, the first thing you should do is actually look at your ventilator circuit and the tubing, because the same kind of noise that you see on that flow pattern can also be generated by water in the circuit or in the catheter mount, which is where the inline suction catheters normally sit if you're using them. So on volume assist control, the flow is constant, so it's not going to change during inspiration, but because flow is passive, during exhalation, you're going to see the exact same noise in the expiratory flow waveform. So both flow will be affected both in pressure assist control and volume assist control in the expiratory phase, but you won't see any noise in the inspiratory phase of volume assist control because it is held constant. But pressure is not held constant. And of course, when you have secretions, this can increase the resistance of the airways, which would cause a larger peak airway pressure, but it should not affect your plateau. So if you are monitoring or using volume assist control in the way that I'm demonstrating here with a pause, then what you'll find is that your plateau should not change, only your peak pressure will change. So that's secretions. Bronchospasm will also affect resistance, so it's good to keep in mind that this is resistance, and then we have flow. So again, we are controlling pressure in pressure assist control, and that's over here. We have flow and pressure, flow and pressure. And because we're controlling the pressure, it's not going to change. So the flow will change. So what happens? Well, it will decrease your flow. So when resistance goes up, your flow goes down. So your flow will not only go down, but the shape will change. So the slope will change and be more flat. And then same with exhalation, you will have decrease in flow and it will be prolonged. Now in volume assist control, you will have the same effect in your expiratory flow. So keep in mind that because it's passive, it's not an active process, it is not controlled, both expiratory phases will act the same regardless of the mode. And then because we are controlling the flow is not going to go down, it's going to stay, and then your pressure is going to go up. And therefore you would also have an increased resistance and your plateau should remain the same. So that's the relationship with bronchospasm. So just by understanding what mechanisms should change, you should be able to look at the waveforms and understand what has changed. Now, the one issue that you may face, particularly in pressure assist control, is that many ventilators auto-scale. And when they auto-scale, it will make this waveform here, it will then auto-scale it to be up here. And then so you will have the similar slope because your time scale is not going to change, but it's not going to look much lower on the screen as it would if you saw it change in real time, because usually it'll auto scale after a few breaths. So this is somewhat problematic, and in some ventilators you may want to turn off auto scaling if you want to notice these subtle changes. But of course, when this happens, your volume will also change if it's an acute change. So if this happened while you were gone and you come back to the bedside, not only is your flow down, but your volume will change. And this is not something that will be hidden by the machine. You can't auto scale the number. If your tidal volumes, if you've lost 200 mils, that's what you're going to see when you return. But in volume assist control, of course, your volume will not change because you're controlling the flow and you are controlling the volume. Okay. So a pneumothorax, this is not a problem that should affect the resistance more than it should affect your compliance. So change in volume, change in pressure. And of course, if you have a pneumothorax, but you are controlling the pressure, you are not going to see a change in pressure, you're going to see a change in volume. Now, what will happen is that you will exhale the volume quickly, and the one graphic that I'm missing from this example, that this is probably the one where it's most important, is I'm going to draw the volume graphic below the flow. So this would be what volume would look like. And then what will happen is it will go down. And then on the next breath, you're going to get a drop like this, and then it's going to give the volume again. So when you have this here, that means you're missing volume from somewhere. And this can tell you that you are sending volume that's not coming back, but the best way is to look at your ventilator screen. You're going to have tidal volume, usually VTI, and you'll have VTE. And those values, the further and further they are apart, the more of a leak you have. And of course, the leak could be into your chest or it could be external. So when you see VTI and VTE, I wouldn't automatically jump and assume you have a pneumothorax. You want to check for any obvious leaks in the circuit, the endotracheal tube, any connections, any ports that may be left open for MDI adapters. You want to check why those two numbers would be off. So for example, it might be 400 delivered and coming back is 320. So you just want to understand where this leak is occurring. And of course, watch your patient closely. You're going to auscultate your patient, see if you hear any breath sound differences. But that's a more concern because you need to know why that's happening. Now in volume assist control, your volume is not going to change, but what will change is your pressure because you've controlled your volume. And so this is not only going to go up, but so will your plateau. So there's a number of reasons why your compliance can worsen, and it's only one of them. So you need to obviously troubleshoot the patient. A pneumothorax is not something you're going to be able to distinguish just by looking at it. Now the volume going in will be controlled, so that won't drop at all. It's still going to go in, and you will still have a difference as well because it won't be coming back. So that's important. And of course, these pressures will both change. Now, atelectasis is also something similar, but it may not always cause a change in pressure. So let's just draw this out again, change in volume, change in pressure. Again, with pressure control, your pressure is not going to change. So if you start having atelectasis, what can happen, of course, is you will end up getting less volume. So this will cause a compliance change, which actually steepens this curve rather than flattening it out. And then you will exhale faster as well. And then over here, you may exhale faster. That's possible. But you will also have an increase in both pressures, peak and plateau. So obviously a lot more investigation needs to happen with this. Your VTI and VTE should be the same. So you shouldn't be losing going in and coming out. But you will notice here your tidal volume is going to decrease from the last time you saw them. Volume will be okay over here, but your pressures are going to increase. So it's important to distinguish what is going on between these two conditions, but you're going to know specifically it's Atelectasis. So this is where auscultation will help. Again, doing a full patient assessment is very important. Are the SATs dropping? Again, this is a compliance change, which could easily be a pneumothorax, except this would tell you that there's something different going on because you're losing volume, whereas this, your volume should be the same. They should not be different between VTI and VTE. And just so you know, ventilators it's not always perfect. They may be off a little bit, but they wouldn't be off by, 80 or 100 mils unless there was something wrong with either the calibration of the ventilator. Maybe you didn't compensate for circuit compliance, but there's usually a leak if it's off by a large amount of volume. So leak is another one that probably should have the volume waveform here. So again, just like you would see with a pneumothorax, volume would go in when the flow is delivered, and then volume would come out, but then it would be interrupted. And then you'd have the next breath would give the volume and it would come out. So this tells you that, again, there's a leak. Your VT inspiratory, your VT expiratory, again, you're going to have discrepancy here. So you just want to make sure that if you can't find the leak, you want to be certain that the leak is not a pneumothorax. And then same over here, you won't have all the volume that you are going in coming back. So your VTI might be 400. Again, VTE will be less. The volume will look the same. It's going to plateau here and then it's going to go down. You're going to see a loss like this. Again, this tells you that the volume has gone somewhere. And if you have a leak, in terms of your pressures, these may be dampened as well, depending on the severity of the leak. Now, a malfunction, of course, is not so hard to distinguish because most ventilators will have specific alarms for malfunctioning. Whether it's an inability to exhale gas, it will alarm. So probably the worst one you could see is occlusion. And if this alarm happens, this is a pure malfunction. And usually what you will see is either, again, if it's pressure, you may still see your pressure, but you'll get no volume going into the patient or very little. It may stutter here. And same with over here, you may get pressure that just shoots up. And then if it reaches your pressure alarm limit, it will dump immediately. And therefore you'll get very sharp increases in pressure that drop right away and you don't get a full breath, your flow goes up and drops right away. And then of course, the other type of malfunction you'll see is something wrong with the expiratory side of things. So you won't have any flow coming out. And that would be the same regardless of the mode. And this is really, when you have alarms like this, occlusion or vent malfunction, the patient clearly needs to be taken off the ventilator and bag mask ventilated, and then really assessing the ventilator, seeing if you can troubleshoot. We don't often keep test lungs at bedsides. So sometimes if you have another ventilator somewhere that can be circuited and brought over, it's sometimes best to do that and then investigate and test the ventilator elsewhere rather than putting it back on the patient and hope that it doesn't happen again. So in terms of alarm settings, the available alarms may differ between manufacturers. So I can't really tell you what alarms to set because you may go to your alarm settings on your ventilator and realize that that alarm doesn't exist on this ventilator. Some ventilators have many alarms, some have very few. But the ones that are probably the most important really depend on the mode that you are in. Okay, now one that's probably universal is respiratory rate. And in terms of where you would set it, it really depends on the patient and the limits you're willing to accept. If the patient has been breathing 20, for example, you might not want to set a rate at 35. So maybe that's an upper limit that you're comfortable with. But if the patient has been breathing 20, that's a really large increase. And maybe you'd want to know sooner to that. But in terms of absolute upper limits, typically greater than 35 is really a good time to pay attention to a patient. But hopefully you're paying attention to them a little sooner than that if it's risen significantly from where it's been before that. Minute ventilation is a decent alarm to have. Of course, this is important in pressure assist control. So I'll put PCAC, pressure control, and that's an assist control mode. Your minute ventilation would be important because if compliance or resistance changes, your volume will change. And you can either do a tidal volume alarm, but again, not all ventilators will have tidal volume per se. They may have a high tidal volume, but to capture low volume states, you will have to look at minute ventilation. So if your patient is on full control and the respiratory rate is not changing because they're sedated or paralyzed, you really need to watch the minute ventilation alarm, specifically in pressure control. In volume assist control, this value should not change. Of course, you would still set your alarm, but the likelihood of it changing without your respiratory rate changing is very low. But when your minute ventilation does change, it would be secondary to a respiratory rate increase or decrease if they've been breathing spontaneously on another mode. Other than that, again, typically a high tidal volume is an alarm that's very commonly set and probably worth noting if you are trying to obey the laws of lung protective ventilation. And of course, peak inspiratory pressure is most important. Now, most ventilators that I've come across don't have specifically a plateau pressure alarm, but the reason is that when plateau increases, your peak pressure increases. So if you are using volume assist control and you have a waveform like this, when plateau increases, your peak also increases. So it's you're not going to get an increase in plateau without an increase in peak pressure. So setting your peak pressure at an appropriate level to which you would want to know if your plateau increased. So for example, if my plateau, if I don't want my plateau to be above 30, but my peak pressure right now is 40 because I'm ventilating my patient like this with volume assist control and a pause. If this is 40 and this is 30, well, I'm likely going to set my alarm. I don't want this to go much higher than that. I probably will set it 5 above, but it would have to be 5 above this rather than this, of course. So you would set your pressure at 45. Now, if you want to limit to 30 and your plateau is 28, then clearly you need to set whatever your peak pressure is, you want to set it above so that you will capture any change that will get to the limit you want. But just keep that in mind. You need to set your pressure above your peak airway pressure if you are trying to provide a safe plateau pressure. So those are probably the main alarms that should be set. Again, many will have other sets. Some will have high and low PEEP, again, which is important. But generally, if you've set PEEP, you want to know if you have intrinsic PEEP. And many ventilators, even if you don't have a high PEEP alarm, will actually tell you if you have auto PEEP as a problem. So respiratory rate, definitely set that. Minute ventilation, high tidal volume, and peak inspiratory pressure are probably the most commonly and most important alarms that should be set. If you are in pressure support, you will have a apnea time, which is part of the alarm setting screen typically, but you want to have an apnea time. And also review your settings always. You don't want to deliver the settings that were used the last time the ventilator was used, just in case they are inappropriate for that patient. So that's it. Nice, short and sweet, just a description of what is important during these conditions to look at depending on which mode you use. And I have time for any questions. And I'm not sure if Neil's back. I haven't been back to the screen yet. Let's see. Oh, wow, yeah. Sure. What do you consider normal resistance in a patient on mechanical ventilation? That is a fantastic question. So normal resistance in an intubated patient with a normal size endotracheal tube for them would normally 10 centimeters of water per liter per second is an acceptable resistance. We generally start to be concerned when it's 15 or higher in terms of airway resistance. So if you're measuring airway resistance and the resistance is 15 or higher, if it's been like that the entire time, then that's maybe you're already aware of it. But if it changes and it increases to that, that's a significant increase in airway resistance. And you will start to have some issues with ventilation, particularly if that resistance is not improved when they start weaning. This may be a concern. So 10 is completely, so anything 10 or lower, I'm not concerned at all. As it starts to get closer to 15, I start thinking, okay, this is getting kind of high. But above 15 is really considered high resistance.
Okay.
So let me look at this.
I'm back online here. I don't know how much,
Okay.
I don't know exactly what happened there, or how much I gave a great talk to myself, perhaps.
Yeah, I finished my talk, Neil. I jumped in and finished my talk, so now I'm just fielding some questions here.
Okay. When did so this is the trouble with this system, is that it was unapparent to me that I wasn't broadcasting.
Ah, okay. So I'll just hammer through some of these questions here, and then we'll get you finishing yours. So VTI and VTE, the difference in pneumothorax is something you would notice if you were monitoring every cycle, right? Otherwise, after a while, the pressure in plateau and lungs will equalize, assuming it is not a tension pneumothorax. Let me reread that. I think I'm reading that too fast. So the VTI and the VTE difference, yeah, you would not notice that unless you're standing staring at the ventilator screen, that's for sure, because there's not separate alarms for VTI and VTE or a difference in the two. After a while, the pressure in the pleural and the lungs will equalize. So assuming it's not a tension pneumothorax, correct. Once the lung starts to collapse, however, so if the pressures equalize, the issue is that so long as volume is going out of the lung, as soon as the lung starts to collapse, then that's when your compliance starts to change. And so you should start seeing an increase at that point. But typically you will, again, if you have alarms set very closely, you should notice before a tension pneumothorax, unless you're in pressure assist control. In that case, you would have to make sure that your low minute ventilation alarm is set relatively tight, because your volumes will change. So if your patient is passive, then you should set your low minute ventilation alarm relatively tight to what you are aiming for to capture that acute change, because you definitely won't see it in the pressure. Would a bronchopleural fistula show up as a leak? Yes, VTI, VTE, and then of course if you don't have a test tube in at the time, then it definitely will start to worsen your tidal volume, and it will also worsen your, if you're in volume assist control, it will change your PEEP and your plateau. Okay, will you expect, what would you expect to see with a mucus plug? So if you have a mucus plug, it's going to start to act more like a very obstructive type of property. So you will get similar to what I showed with bronchospasm, where if you're in pressure assist control, your flow is going to be diminished, both during inspiration and expiration. In volume assist control, you will have, again, high airway resistance, and you will have diminished expiratory flow. Intrinsic PEEP, yes, so intrinsic and extrinsic PEEP. So extrinsic PEEP is essentially the setting on the ventilator, that's external PEEP. And then intrinsic PEEP is any PEEP in which the patient has above and beyond what you've set. And typical reasons for that would be a respiratory rate that's set too fast for the patient to exhale all the volume, or they have airways that are prone to collapse once they reach a certain choke point, and then you may have some trapped pressure that does not release from the lungs. But the difference has to be, the way to determine the difference typically is by doing an expiratory pause on the ventilator, and then you can distinguish between those two pressures. You should see a rise in the expiratory pressure when you perform the maneuver. Some modes can tell you an estimated intrinsic PEEP based on where it senses the patient starting to take an inspiratory effort and how much pressure would likely be back in the ventilator. But to get an accurate measurement in a passive breathing patient, you do an expiratory pause. But doing an expiratory pause in an active patient does not typically work very well to determine intrinsic PEEP. So for that, you would need sort of, as I said, some ventilators will have an estimated value for intrinsic PEEP for a patient on a spontaneous mode. But to capture it in a passive mode, you have to do a hold.
Okay, so Tom, there are a couple more questions here, and I've had several people text me and tell me I cut out about the 8-minute mark, so I just give an outstanding talk to myself. So we'll try to reboot it again in a few minutes after we answer some more questions. How much is an acceptable leak, Tom?
Yeah, that's a good question. If you're aware of the leak and it's due to a specific reason, if you have a bronchopleural fistula, then you may have to deal with specific leaks. But in terms of a leak or a noticeable difference in VTI and VTE, generally you'll see, I've seen clinically anywhere between 20 and 50 mils. And sometimes it could be the testing of the circuit, for example, is done when you occlude the circuit, but then you add a catheter mount for your inline suction catheter. This may change some of the volume that the ventilator is not compensating for. So generally up to 50 mils, I'm not normally concerned about. Above that, you start to wonder why it's not like that. Sometimes if you put a separate pneumotac into a ventilator, it may be very off from the ventilator itself, and that's due to the ventilator not compensating for compressible volume in the circuit, which is usually an option after you test a ventilator. You say, yes, compensate for it. But typically a leak under 50 mils, I'm not normally worried too much about. I always try to find the leak. If it's less than that, I'm happy, but unless it's more than 50, I don't normally chase it.
Great. Now, here's a pediatric question for you. Do small endotracheal tubes in children mean the children tend to have higher resistance during ventilation?
It really comes down to the flows being delivered. I don't work a lot. I haven't worked in pediatrics or neonatals, but you would be delivering much slower flow rates to those tubes as well. So what a normal resistance is in a neonatal or pediatric patient, I actually don't specifically know the normal values off the top of my head, as I've been adult my entire life. But it may not be drastically different. I know compliance is drastically different, so I imagine the resistance values are very different, but they are relative to flow. So it would be a different kind of beast.
Yeah, the peak inspiratory flows are obviously a lot smaller in a small child as well, so that's matches there. And here's another question. Okay, here's just so we can clarify the concepts here. If there's a mucus plug, would you expect compliance to go down as well, leading to increased plateau and airway resistance?
So if you had a mucus plug, yes. So sorry, I should have mentioned that earlier. I was thinking of mucus plugging that's not a plug yet. Yeah, once you have a plugged in airway, then you should see changes in compliance because you are now plugging off an area of the lung. So you should see an increase not only in peak pressure, but also plateau. And you would really only see, I mean, you may see some resistive changes, but you would see more resistive changes if flow is actually getting through it, because you would get a lot of turbulent flow and back pressure from that. But if you have a full mucus plug, you're going to have a compliance. That
can be a sign that you've moved from having increased airway resistance with secretions to a complete plug when you switch from a resistive pattern to a compliance pattern. And as you say, the compliance has changed because if you've plugged off your left main stem bronchus, now you're only ventilating the right lung.
Yep.
Good. How to recognize partial tube obstruction? Any alarms?
Well, if you're in volume assist control, you will have your peak pressure alarm will go off for sure because the partial tube obstruction would send off your resistance. If you're in pressure assist control or pressure support, you should have a low minute ventilation alarm limit that is relatively close to what you're at, because that's what you would see a drop in your volume. But I mean, my talk yesterday, I explained why I like using volume assist control. In the acute patient, it really helps to distinguish most of these issues. Now, in the passive patient on pressure support, it becomes much more challenging to distinguish between these issues. So you're going to end up with a patient who has lower tidal volume, and you have to try to figure out, is this tube obstruction? Is this atelectasis? Is this increased airway resistance, of the airways rather than the endotracheal tube? So it really becomes more of a challenge when you're in a pressure targeted mode because so many things will change your flow. So it really does involve a full testing or assessment, sorry.
Okay, and maybe just the last question, then we'll try to get my talk finished again, is about measuring airway resistance in is it important to measure expiratory airway resistance?
So some ventilators will estimate expiratory resistance. There's really not a maneuver that can be done properly to do it. It needs to be estimated because you have typically an exponential change in flow during exhalation. So it can be helpful to monitor. If it changes, then clearly it could tell you that you may be having some bronchospasm issues, but it's not something that can be measured routinely by doing a maneuver. The ventilator would have to provide that value, unless you're very good at doing least fit squares calculations yourself, which I'm not.
No, me neither. All right.
And Neil, before you begin, I don't know if it's your notifications that are going off on your phone or your watch.
Yeah, but that tells me at least you can hear me. So
yes, I can hear you.
I'm good with that.
If you get cut off again, I will send you a text message.
Yeah, because before I had my phone turned off and I was being good and not paying attention to anybody trying to interrupt my talk, and I didn't recognize the number. No, anyway. Okay, we're going to go back to spontaneous breathing here. I'm going to share my screen again. Okay, I think I got several people telling me I was just around. We just finished talking about the concept of patient self-inflicted lung injury, and showing that ventilation-induced lung injury can definitely occur. And we were just, I believe, talking about this concept of Pendelluft, swinging air. And this is something that we're just appreciating with new technology called electrical impedance tomography, which shows that when the lung is injured, I mean, this doesn't happen in normal lungs, but when the lung is injured, when spontaneous efforts are combined with positive pressure, this can lead to the breath being delivered into the lung in such a way that almost all of it goes to the bases first, and then it comes back up to the top. And that means that essentially you're delivering a double breath, because rather than one volume being nicely globally distributed, it's all going to one part and then all coming out to another. And that may be another mechanism by which spontaneous breathing is leading to lung injury in severe cases. And this is backed up a little bit by an animal study here in rabbits, where Takeshi Yoshida had two different severities of lung injury. One was just saline lavage, a relatively mild injury, and the other was saline lavage plus intentional ventilator-induced lung injury. And there's some very interesting effect modifier here, where in the mild lung injury group, it's the patients who were breathing spontaneously, the rabbits, I should say, that were breathing spontaneously, who had better looking lung parenchyma. But in the severe injury group, when they were paralyzed, there's relatively less injury, but severe injury plus spontaneous breathing led to extremely disturbed lung parenchyma here. Okay, I am on slide 12. Okay, and give an extra click so that we can show the details here at the bottom. The point of this slide is just to show the fine print in the table of one of the large PEEP trials, because up until now you'd be forgiven to say, oh, we should never allow spontaneous breathing. But here we see that, in fact, in all of the trials of ventilator-induced lung injury, okay, we don't see the good slide, so maybe I'm not on the right slide. Can you tell me what slide you're showing? Yeah, what's it look like? Okay.
Lung open ventilation table.
Okay, that's good. And does it say, and then click once more and it should bring up a little call out box that says for tidal volume, that's where we are? Okay, perfect. Now, good, this is good. Thank you very much. So this is just to point out that as patients are getting better and their FiO2 is 40% or less and their PEEP is 10 or less, that in fact, we've allowed these patients to take larger tidal volumes, and outcomes have been okay. So there's some signal that in the recovery phase, we can be more relaxed about this. Next slide. And also there's the potential effects on the diaphragm with that having no spontaneous breathing may be injurious to that. In this 3D graph here, the y-axis is the change in diaphragm thickness over time. The x-axis is the number of days, about 8 days here shown on the graph, and the z-axis is the amount of diaphragm activity. So when there's no diaphragm activity, there's a rapid decline in diaphragm thickness, loss of diaphragm muscle leading to atrophy, which is associated with worse outcomes and longer duration of ventilation. And contrast that to the patients who maintained a relatively normal amount of diaphragm activity. Their diaphragms remained unchanged, and they got off the ventilator sooner. So there's some balancing to do here between allowing and avoiding spontaneous breathing. Next slide, please. So questions, when do we allow spontaneous breathing? How much to allow? And another factor to consider is if we say, well, let's maintain normal effort levels, that implies that we have to actually be able to measure effort. Next slide. So here are the pros and cons of allowing spontaneous breathing in ARDS. On the pro side, we could prevent or minimize diaphragm atrophy, this so-called overassist myotrauma. We might improve hemodynamics because we're generating some negative pressure in the chest, and that can both increase venous return and mean that we don't have to use as much positive pressure, which may make the right heart happier. The patients are breathing spontaneously, so maybe you'll be able to get away with less sedation and its associated adverse effects. And you're progressing the patient towards liberation and getting them off the ventilator by having them doing some of the work of breathing. On the opposite side, there are some risks. Let's go back to the previous slide, that spontaneous breathing can lead to direct overdistension injury by having larger tidal volumes than we want. There's this pendulum phenomenon that can happen in injured lungs. Also, increased risk of increased lung perfusion and potentially more edema because of negative pressure within the interstitial space. And when we have spontaneous efforts mixed with some machine efforts, then we're at risk for dyssynchrony and double triggering, which is a double breath, which can also injure the lung. And important effect modifiers, which probably swing you more towards avoiding spontaneous breathing, are the degree of severity of ARDS, the smaller the baby lung size, and by that I mean the more of the lung that is collapsed and atelectatic, and the smaller amount that's left to accept the ventilation that we're giving. That's the so-called baby lung. Patients with high drive and who are making big efforts, and if they have injurious ventilator settings, all those things would make spontaneous breathing relatively more dangerous. Next slide, please. So how to measure effort? A few words about that. I don't expect you to start measuring pleural pressure if this is your first time interacting with a ventilator, but just so you know, this is a reference standard for effort would be an esophageal balloon. Next slide. And that allows you to measure pressure time product and know exactly what the patient is doing and when. Perhaps more useful for this talk, though, is that there are several ways that we can measure this and estimate effort relatively easily and non-invasively. Next slide. So Irene Tellius, one of our clinical and research fellows, has just published this nice paper as part of her PhD work, showing that the P.1, this is the airway occlusion pressure measured in the first 1/10 of a second of a breath, shown here. There's a brief inspiratory hold, and the patient makes an effort, and the machine will automatically measure the deflection of pressure. Next slide. This correlates very nicely with patient effort. Next slide. And you can use this as a screening tool to try and rule in or rule out too much or too little effort. If the P.1 that the ventilator is displaying for you is less than 1, you can be pretty confident that the patient's effort is lower than normal. Conversely, if the P.1 is above 4.5, and by above I mean more negative, if it's -5 or 6 or 7, then you can be very confident that the patient is making higher than usual amounts of effort. And this is a value that most ventilators will either display automatically or can measure with a simple press of a button. Next slide, please. We talked last night about the occlusion pressure. And again, this is a simple way that you can use to estimate effort just by doing an expiratory hold, or sometimes a stealth negative inspiratory force maneuver here will measure your occlusion pressure. Next slide. And you can use this to estimate the amount of work that the patient is doing by multiplying that by 0.7, gives you a P-mus value. And normally we're targeting normal levels of 5 to 10 for that P-mus value, the muscular pressure that the patient's generating. Next slide, please. Next slide, skip this one. Now, you have a patient on pressure support, and in this example, the pressure support level is only 8, PEEP is 5, and the tidal volume the patient's generating is very large, 750 mLs, and that's likely mostly due to the patient's own inspiratory efforts. So controlling tidal volume in this setting while keeping the patient on pressure support can be challenging. If you turn down the pressure support from 8 to 5, likely the tidal volume is hardly going to change, if at all, because the proportionate amount of work is being done mostly by the patient. Next slide, please. So how can we do that? Well, you could paradoxically increase the inspiratory assist a little bit here, and that might just get the patient's drive under control, but you have to watch tidal volume very carefully there, obviously. Increasing PEEP sometimes in this setting can help if hypoxemia and a low end expiratory lung volume are the problem. And here we might consider, if those two things don't work, this is when we might be considering sedation and neuromuscular blockade if the patient's severity of illness warrants that. Next slide, please. So now let's talk about synchrony and asynchrony. Once we have patients breathing spontaneously and initiating breaths, this now implies that we have to get the ventilator to pay attention to the patient, and ideally they should work together. So if something is synchronous, that means that the ventilator is delivering a breath when the patient is making an effort, and the ventilator at the same time is not blowing air into the patient when the patient is trying to blow out. Next slide, please. Asynchrony, when you look for it, can happen pretty frequently. In this study where they looked at tracings and had esophageal balloons to check for asynchrony on everybody, they saw that 25% of the patients studied had more than 10% of their breaths being asynchronous. And this was associated with a significant increase in the duration of mechanical ventilation for those patients. Not necessarily all causal, there's some selection bias here, but it may be a contributing factor. Next slide. And this is just to show that you can do this automatically and see similar frequent dysynchronies. Next slide, please. So in terms of types of asynchrony, classify these into different categories. One common one is ineffective efforts or delayed triggering. We also see cycle off asynchrony, and in fact, cycle off asynchrony in turn can cause ineffective efforts or delayed triggering. And then the other thing that we are concerned about a lot is double triggering, where a patient with a high respiratory drive takes 2 breaths in one and gets twice as much volume as we've touched on already. Next slide, please. So here are a couple of ventilator tracings here, airway pressure and flow time on the top 2. And then on the bottom, we've got an esophageal pressure, which is our source of truth in this in this setting. Obviously, we don't have these in most patients, but if we start looking in the middle graph, the flow time tracing, you can see little blips in the flow time tracing that when you look down, those are associated with small little efforts that are not being caught by the ventilator. On the right-hand panel, the amount of inspiratory support has been turned down. You can see on the top line, the peak pressures are much lower. And note also that the breaths are a lot shorter. The time for each breath is shorter. And then look down at the bottom panel on the right, and you can see that the esophageal pressure swings are much bigger. The patient's making bigger efforts because they're not being over-assisted now. And now every breath is synchronous. Next slide, please. Here's another example of, and this is delayed triggering. If you look at the figure in the top right-hand corner here, this patient has some auto peep. And so the patient has to do isovolumetric work to lower the pressure enough to get flow to go into the ventilator so that the ventilator can know that the patient is trying to make an effort. Next slide. Here's another example of delayed triggering. And on the top here now we have the electrical activity of the diaphragm, which is our source of truth in this example. This is collected with a special NG tube that has a series of electrodes on it, allows us to measure diaphragm electrical activity, which is as close as we get to plugging directly into the patient's respiratory center. And if you look at this breath in the middle here, the patient starts breathing in, as we see on the top line, and the ventilator hasn't done anything yet. And there's a bit of a delay until the airway pressure and the flow start. And then the patient's synchronous for a small amount. And then as soon as the diaphragm electrical activity has peaked and starts to go down, that means the patient's relaxed and is in trying to be in expiration. But in fact, all of that cross-hatched time there, you can see the ventilator is still in inspiration. So this is an example of both delayed triggering and cycle off desynchrony, where there's very little of the patient's inspiratory neural inspiration that the ventilator is in sync with. Next slide, please. And we'll skip this one. Next slide. And finally, here's just one more example of double triggering, and just give one more click for me. So double triggering, where in the middle example with the arrows here, the patient has initiated the breath. You can tell that because there's a small deflection in the pressure time tracing just before the breath has started. But as soon as the ventilator has cut the breath, it's reinflating again because the patient is still making an effort. And you can see that in this example, this results in a measured tidal volume that's significantly larger than our target tidal volume. Be aware that this example you might easily catch just by looking at the tidal volume tracing, but in some ventilators, this won't show up like this. You'll only be able to detect it looking at the pressure and flow time curves, because the ventilator thinks as soon as it's finished giving one breath and it starts giving another breath, even if that's a double trigger, that's counted as a new breath, and it gives a different tidal volume. Sorry about that. Next slide, please. So we've talked about how to recognize asynchrony. How do we fix it? Next slide. So here's one very effective method, and that's neuromuscular blockade. Obviously, when we have patients sedated and paralyzed, they're completely synchronous with the ventilator. And this actually may reduce mortality in certain severe ARDS patients early on in their course. And it may be necessary in patients early on in the course of the disease. But obviously, this is not a feasible solution as we continue ventilatory support and we want to get patients moving towards recovery. Next slide, please. So how do we make patients more synchronous? Well, first we can monitor and treat and match auto peep. That's the pressure that's inside the chest, again, if the patient hasn't completely breathed out. And we can make the synchrony part of the ventilator happier with that just by setting external PEEP to be relatively close to what the auto PEEP might be. If you want the patient to be synchronous, then although we like using volume cycle assist control early in the course of the disease when the patients are very sick, if you're trying to have them more awake and breathing spontaneously, it's hard for them to be synchronous on volume assist control because the only thing that you've given control to the patient of is the ability to initiate a breath. Everything else about the breath you've set on the ventilator, including how big a breath it's going to be and how it's going to be delivered in terms of the flow pattern. If you're trying to maximize synchrony during pressure support, just as we talked about last night, you want to use lower levels of pressure support because that allows the patient to help dictate the size of the breath. If you are over assisting a patient on pressure support, then all they do is trigger and the rest is determined by the ventilator. They have no option there. And you also increase the length of duration of the breath and put the patient more at risk of cycle off asynchrony and missed efforts. In those patients who do have a lot of airway resistance, then you may need to increase the cycle off trigger and shorten the breath automatically like that, as we discussed last night also. There are some advanced modes that can make patients more synchronous, but I think those are a little out of scope for tonight's discussion. Next slide, please. Here's another method that I just put up more for your interest. This is still somewhat experimental, but rather than fully paralyze people, another option that we could do is use partial neuromuscular blockade. And this nice paper out of our friends in Amsterdam showed that you can titrate rocuronium by giving small little boluses, not to train of 4, next slide, but instead to tidal volume. So they were able to lower tidal volume right to 6 mils per kilogram using partial neuromuscular blockade and maintain that for some time. Whether this is something we can do in a larger scale, we're still exploring, but I just put this out here for your interest. Next slide, please. Another way to protect the lung and try to make patients synchronous with less support is to transfer the work of breathing away from the lung and onto an extracorporeal device using extracorporeal CO2 removal or Ecmo. Next slide. This is not a new phenomenon. We've known since the 70s that you can completely control ventilation in normal animals by removing CO2 extracorporeally. Next slide. And even in patients, this has been reported since the mid-80s from Luciano Gattinoni here, using extracorporeal CO2 removal to try and reduce the amount of inspiratory positive pressure that we need to use, making the patients breathe in a more lung protected fashion. Next slide, please. So to getting closer to wrapping up, here's the opinion-based medicine part of the talk. When to allow spontaneous breathing in ARDS. If the patient looks like the one on the left and they have a white x-ray with a lot of collapse and atelectasis and a small baby lung, then I'm pretty strict and rigid about setting tidal volumes of 6 mils per kilogram or even lower, watching for a driving pressure that's below 14 and a plateau pressure less than 30. And if that requires sedation and paralysis, then that's what that requires. The patient on the right could be more challenging, and this might be somebody with milder ARDS or with a type of vasculopathy that we're seeing in some of these COVID-19 patients with relatively reserved respiratory system compliance. And here, I don't set a larger tidal volume, but if the patient's taking somewhat larger tidal volumes spontaneously, then I'll often live with that as long as their oxygenation is not too terrible and they're not making huge amounts of effort. Next slide, please. So in this two-segmented talk, I've tried to tell you that the impact of spontaneous breathing during ARDS depends on both the timing of when you're doing it in the course of the disease and the severity of the lung injury at the time that you're doing it. I've tried to show you that measuring patient effort is potentially pretty easy and maybe important. Asynchrony is common, and that may have an impact on clinical outcomes. And when you're allowing spontaneous breathing, consider normalizing efforts to protect both the lung and the diaphragm at the same time. And overall, as you're getting more and more comfortable with ventilators, I would say I'd encourage you to pay attention to the graphics that are on the ventilators and available. Watch those pressure and flow time waveforms that Tom was drawing for us a little earlier tonight. Next slide, please. And just to wrap up, this is a little algorithm that we put together in Lancet Respiratory Medicine last year that tries to standardize or streamline when you break out different adjuncts of treatment for ARDS patients. So if the PF ratio is low, and especially if the longest twice compliance is low and you think the patient should be recruitable, then we would think about prone positioning. Consider neuromuscular blockade and higher PEEP if you think they're going to be recruitable. And only after you've done that is the time to think about ECLS. And with that, I will see the next slide. And I think now that's us finished. One more click. And now we'll be happy to take questions. Thanks very much.
Thank you, Neil. So we have quite a few questions. Let's start off with the first one. How is Pendel affected by patient position changes? Is it better or worse to have the patient seated or sitting up?
Yeah, that's a great question. I don't think that we don't have that answer precisely. I think that when you have the patient sitting up, it does bring another sort of degree of freedom into the setting of volume distribution. And if they're fully, the trouble is when we say sitting up, we don't really mean sitting like I'm sitting in the chair right now. We mean sort of inclined a little bit in the ICU bed. So it's hard to know what that does. I think it depends on the body habits of the patient. Sometimes we're just kind of folding our patients a little bit, whereas if they were actually sitting in a chair, that would be very different.
Yeah, I think it would depend on how it affected their inspiratory effort, because that would drastically change. Okay, so next one we have, would P0.1 measurements be different in spontaneous versus controlled ventilation?
Yeah, so it's a great point. You can't, you have to be breathing spontaneously in order to measure P.1. It's because in controlled ventilation, there is no patient effort. And so there's no negative deflection to measure. So
well, they could be triggering. So maybe if they are triggering in an assist control mode, then yes, P0.1 would be the same. But if they're passive, then it would be useless.
Yes, that's what I mean. So if it's an assist control, if the patient's making some efforts, then the ventilator will display it. But if the patient's not triggering breaths, then there is no P.1 to measure.
There is maybe some differences that have been described before between flow and pressure trigger. Some people believe that if you are using a pressure trigger, it may be more accurate. But I've played around clinically, and I haven't noticed a large change in or a noticeable change in P0.1 when I've played with different trigger sensitivities, but it is possible.
Yeah, different ventilators measure them slightly differently. So there's some, you can take it with a wiggle room of plus or minus 1 or 2, but for sure, if you're getting very low levels, then or very high levels, then you can be confident that you're over or under assisting.
Yeah. Were the patients fully sedated for partial neuromuscular blockade? Presumably, this could be anxiety provoking in an awake patient.
Yes, definitely. So again, I put that up just as an interest of what's on the next level out there. This is not necessarily something that's ready for prime time everywhere, and until we have a very more experience with it, the initial setup for sure is to have patients sedated as if you were going to have them paralyzed, because the reality is you might easily overshoot and have them completely paralyzed.
Right. Would an inspiratory pause set in volume control mode likely result in cycle off asynchrony?
If the patient is breathing spontaneously, then they may be quite desynchronous in terms of when their neural inspiratory time ends. You've taken all control of that. Again, this is why we use volume control early on when we want to be in charge and we're not letting the patient breathe too much.
Yeah, and just to clarify too, that an inspiratory pause, interestingly enough, for those who have ever tried PAV Plus, it actually performs a 0.3 second inspiratory pause every 4 to 10 breaths. So interestingly enough, it's relatively well tolerated by a patient. Of course, it adds time to a breath, so of course it causes some issues with synchrony, but it's generally well tolerated at least.
Yeah, that's a nice point. That small, if you're worried that the patient's going to be actively fighting that pause, if that's what you meant by synchrony, then I agree. That's not, because 300 milliseconds is about the length of time that it takes your brain to figure out that your airway is closed. Right. And then by the time that you figure that out, it's that your 0.2 seconds hold is gone already.
Yeah. How does neuromuscular disease or diaphragm weakness affect P0.1?
So it doesn't have so the short answer is it doesn't have a big effect because P.1 is reflective mostly of drive. Somebody has to be extremely weak and have almost frank diaphragm paralysis before it becomes unreliable.
Answering one of the questions that was just asking to clarify something. So how did the results of the ROSE trial affect your use of neuromuscular blocking agents? Do you reserve it for patients displaying asynchrony, although much of asynchrony is not recognized?
So I had, just for the sake of time and because of this talk, I took out a bunch of slides about the ROSE trial, which was a recent randomized trial conducted by the Pendel network, which is the new iteration of the ARDSnet in the US, that was trying to reproduce that accurate study that I showed with the mortality reduction, which was a French study done 10 years ago. And they showed in 1,000 patients, they showed no difference. But there are some differences that are important there. The American trial used higher PEEP, where the French trial used lower. And so one explanation may be that when you use higher PEEP, you have somewhat less asynchrony. You may have less drive. You may have less drive and less double triggering. There's also a question that because in the French trial they kept everybody deeply sedated in both groups because they were trying to have it as a blinded trial, they may have actually induced some inadvertent reverse triggering in the control group that might have been harmful and amplified the effect. The biggest thing for me is that the ROSE trial recruited patients extremely early, and if you look at in the supplement, they all had a huge increase in their PF ratio within 6 or 8 hours without any major changes to the PEEP, which I think tells me that in their efforts to get early patients in, they recruited a lot of patients that maybe weren't as sick as they initially had thought. So overall, I still think that in severe ARDS patients, there's definitely a role for neuromuscular blockade for avoiding dyssynchrony and maintaining tight control over tidal volumes in the first day or two, especially those that are more severe with persistent severe ARDS.
Okay, just a couple more questions. Why don't we see a patient's self-inflicted lung injury in DKA patients? Some of them take 40 liter-minute ventilation to compensate for acidosis.
Yeah, but most of those patients have normal lungs. So remember that the self-inflicted lung injury is usually a double hit phenomenon. So there's some lung injury, and then the patient makes it worse. In order to get self-inflicted lung injury with normal lungs, you really have to hyperventilate, and we don't see that a lot. Although it'd be interesting you might hypothesize that sometimes maybe some of the high altitude pulmonary edema that we see in altitude might be some self-inflicted lung injury there, because that's another place where we see extreme hyperventilation of the sort that was induced in those sheep.
And let's see, we have two more. Can you cover why increasing pressure support will help if tidal volumes are high in improving or mild ARDS patient? Why not reduce pressure support or just allow CPAP?
So I think there's not a definite right answer here, and sometimes you have to experiment with the patient to see what happens. But the rationale here is that if the patient is under supported in this example, that may reduce their end expiratory lung volume and give them a very high drive, whereas paradoxically increasing the pressure support level a little bit may improve their end expiratory lung volume, may make them a little bit less dyspneic, and paradoxically reduce their overall drive and tidal volume, because the tidal volume is going to be generated by the combination of both the positive pressure that you give and the negative pressure that they generate. You can't tell that for sure until you try it. So you go and fiddle around and you turn it up and see what happens. Obviously, if you turn up the tidal volume and you turn up the pressure support and the tidal volume goes even higher, then that's not for that patient. But in some patients, that may work.
Yeah, I think it's important to acknowledge whether or not they respond to the increased support by decreasing drive. If they don't decrease their drive, then it's just more injurious for sure.
Exactly.
So there's one more question, Neil, and I have just one clarification because I think I may have added to the confusion and someone asked a question. So when I mentioned about pressure versus flow trigger for the measurement of P0.1, Neil did clarify, but I'll be very specific. Most ventilators, it's a maneuver. So you actually press a button, it does an actual occlusion, and then it takes the first, like it's not expected by the patient. It waits for the trigger and it does an occlusion. So it does not matter at all what your trigger sensitivity is if you're doing a maneuver. One ventilator, for example, the Servo I and the Servo U, it estimates it in real time. And some have described that perhaps setting pressure versus flow sensitivity may make the estimation difference. But I haven't noticed a significant difference that would be clinically relevant when I've compared the two triggers on a patient at the bedside. It may have to do with the strength of the effort as well. But
yeah, I think those are things that might be important in the respiratory physiology lab. But at the bedside, we can take these P.1 numbers as sort of plus or minus 1 or 2, and use those to make clinical judgments.
I agree. So last question, how often do you use Ecmo for ARDS?
Pretty often. I think that we're generally of the belief that the Eolia trial was the most positive negative study that has been published in the England Journal for a while, and considering the crossover rate, there's a lot of signal for benefit there. So we're being a little bit more restrictive this week with all the COVID activity happening generally, but our usual operating characteristics are to apply the Eolia entry criteria for considering Ecmo, but that still comes after the patients have been stabilized, had their PEEP adjusted, had a trial of prone positioning to see okay, is their oxygenation very bad, or their lung injury, their ventilation pattern still injurious after I've tried my best to optimize it.
And I think that's important. People tend to jump to certain strategies, or they want to jump to strategies before using something that already has evidence, like stronger evidence to support it as a first line versus a second thing to do. Yeah. And
that's sort of what we were trying to emphasize in that algorithm that I put up at the end of the talk there, saying that yes, everybody likes to do Ecmo, but let's do the simple, cheap, and effective things first.
Right. Okay. I don't know if we have any more time. Some more questions have come in, but I don't know if we run out of time or didn't look at the timer there. Okay. Do you want to just, we'll just capture a couple more here. Sure. Have we seen, or I guess you've seen or heard, many COVID patients survive after Ecmo?
So it's interesting. In many places, where they normally use Ecmo a lot, like in Milan, they hardly put anybody on Ecmo. And that was because they were completely overwhelmed with patients and couldn't afford it from a human resource standpoint. We've got a number of patients on Ecmo, and I've already successfully decannulated 3 patients from Ecmo at Toronto General in the last week. And we also hear from other places around the world that they're using Ecmo. They're putting everybody on Ecmo in Japan, apparently, with reported good results. And in Paris, Alain Combs and his group are using it a lot as well. So I think there's some very early reports out of China which have said, we had 15 patients who were on Ecmo and they didn't do very well. But there's very little data about who those patients were, how they were selected, who the teams were looking after them, what else was going on. So I think that right now we're in the position in Toronto to be able to continue to offer this, because it is a significant increased resource compared with just providing mechanical ventilatory support. So we're taking this sort of day by day or week by week, but for now we're happy to be able to support these patients, and I think we've been able to save a few people.
And I think I might know your answer to this question, Neil, but for patients with metabolic acidosis, do you just put them on pressure control and allow them to have higher tidal volume?
No. With metabolic acidosis, it makes our ability to tolerate hypercapnia more difficult. I'd like to try and understand why they have a metabolic acidosis and fix that. So that might be an indication to dialysis, if that's a common indication, or it's resuscitating them and fixing their lactate. But within reason, if they have a metabolic acidosis and their pH is less than 7, then yes, I'll tolerate slightly higher tidal volumes and try and get their tidal volume up, their pH up into a survivable range. But it's not my preferred method.
Yeah, and I think we should acknowledge for those watching as well that in every ARDS study to date, when someone is severely acidotic, when they reach a certain pH criteria, it is recommended to increase tidal volume by 1 ml per kilogram predicted body weight to a maximum of 8. So it's reasonable to allow higher tidal volume, but yeah. And there was just one more comment that was just asking to repeat about the cycle off asynchrony, but I'm not sure specifically what, which element of it.
Just to cover that again, cycle off asynchrony happens in pressure support often when the pressure support level is too high, and that leads to a long breath, because if the pressure support level is high, the peak inspiratory flow is high, and therefore it takes longer to come down to 25% of a higher flow. And in that setting, often the right thing to do is to turn down the pressure support level, and the breath will shorten and the patient will be more synchronous. But sometimes the problem is with airway resistance and a very slow decay, and there the solution is to raise the cycle off threshold.
Yeah. And inspiratory effort has a lot to do with it as well, which when you over support someone, they're gonna, if they respond by lowering their effort, it just sort of worsens the delayed cycling.
Yeah.
So, okay, that's it. It looks like we've gone through every question in the moderator deck there.
Perfect. Okay, well, thank you very much, folks, and apologies again for the technical difficulties that we've experienced tonight. I hope that we were able to get some of the messages across despite that. And we've got one more installment of this series tomorrow night, where Ewan Gallagher and Laurent Brochard will be talking about the final phase about how to get patients off the ventilator. And we thank you again for your attention, and draw your attention to the fact that these all these presentations will be posted online shortly at our mechanical ventilation course website, mechanicalventilation.ca, and also at the CCCF website, criticalcarecanada.com, that you may still be able to see up there. And point out that we have a full 2-day course for advanced mechanical ventilation set to happen virtually, an interactive virtual course on June 2nd or 3rd. Thank you very much, and
Great.
good evening.
Thank you.